episode of Retina Chats. We're honored today to have Dr. Ahmed Sallam with us. He was visiting Alexandria, and we took the chance to meet him and to record this episode. Hello, Dr. Ahmed.
Hello, how are you doing? Thank you so much for the kind invitation.
And as always, with me is Dr. Mustafa Manhani. Hello, everyone. We will be talking today about various cases of endophthalmitis and uveitis. So let's start. Dr. Mustafa will start presenting his first case.
This is a case of a cataract surgery that was complicated with an endophthalmitis 1 week post-operative, and it was an uneventful surgery. And when it presented with the hypopyon for the anterior segment surgeon, he was advised to inject this case, and the patient was injected on the 7th day with a counting finger vision for 2 millimeters. Then the patient was on follow-up, and after 48 hours, it dropped from counting finger to hand motion vision. On that day, he was re-injected again and was followed up 48 hours later. And at that time, the patient was found to be a PL vision. So, in this scenario, Dr. Ahmed, how would you proceed with such a case if the vision is deteriorating despite that intravitreal injection for 45 antibiotics are taking place, and we don't have still the culture for the vitreous tape that is we are looking for? What is the organism, and how do we proceed further after 2 intravitreal injections?
No, I think it's great questions. This patient had post-cataract, I think it's hard to tell really when did this first present, because given based on the history that presented on the day 7, right?
Yes.
He was injected,
Yes.
then re-injected it again in 48 hours because he or she was not getting better, right?
Yes.
Yeah, so that's probably what I do. I try to inject these patients as quickly as possible. So once they present, we inject them in clinic. We aim to inject them in half an hour, if not an hour. They are injected, done, and we do a vitreous tap. And even if we get a dry tap, we just get aqueous sample and still inject them with vancomycin ceftazidime. Then we would see them 24 hours. But usually, unless we feel that this is like a strep or a gram-negative, and usually these ones would present very early, we would see them again in 48 hours. And then we need to make a decision whether this patient is improving, the inflammation is improving, or it's not. And that's very critical. And if it's not, or we're not sure, then we proceed with vitrectomy and another injection.
And how do you
assess
Yes.
Yeah, I think this is a fantastic question. I think that's the main thing, really. So it's a mix of many things. First, the majority of those patients would have pain. In the EVS, 74% had pain, so only 26% had no pain. Maybe the opposite, 76 and 24. But anyway, 3/4 would have pain. So that's number one. Ask how is the pain? And the patient usually give you a very good answer. The pain is worse or the pain is better. Second is the vision. Third is the AC reaction. Fourth is the vitreous reaction and your view of the retina or the B scan. And then you really need to take all these in account and make a decision whether it's getting better, even if it's a tiny, tiny bit better, or it's getting worse or not, or it's the same.
Okay, so let me ask you, in your experience, how many of your patients get better? Just like an estimate.
The majority, 90%.
Exactly. So this is the message that we want to get out there to our viewers, that most patients do not need vitrectomy, right? That most patients, most post-cataract endophthalmitis cases just need an injection and they do well, and we don't need vitrectomy.
Yeah, exactly. And if you even rather than experience as well, is the evidence in the endophthalmitis vitrectomy study in the 2 arms, the arm that had injection and vitrectomy and the other arm that had only injection, about only 7% needed re-injection.
Okay.
So which means that the eye usually gets sterile with just 1 injection.
Okay.
And let me ask you 2 questions. How many of your tapping come positive with
50%.
It's 50%.
Yes.
And if it's an earlier presentation, like 2-3 post-operative, would you be more aggressive because this is a more aggressive organism like Pseudomonas especially?
Yeah, I think you'd be more aggressive, and you may even like take a decision of re-injection with vitrectomy at 24 hours if it's like aggressive, because if presenting early or thinking, as you said, gram negative or strepped. So yes, I may like do a second intervention early. Although actually, to be fair, sometimes it's hard to gauge whether the patient is improving or not early on. But yes, I would intervene early. But still, I have a day to prepare for vitrectomy, have things set up nicely so that really like we're good to go. And I did not disadvantage the patient by getting them to wait for vitrectomy and delay the injection.
Another question: many surgeons or many ophthalmologists refer to us these cases, and they ask you, "Is this an infection case or a reaction? Just a reaction?" When in doubt, would you advise to inject rather than not inject?
Yeah, no, of course. I think the message is always listen to your heart.
Okay, so if you're in doubt, you would just
Yeah,
tell them inject to be on the safe side.
If
right?
you're in doubt, then you have to treat it as endophthalmitis. Basically, if the vitreous is involved and you don't have really a very clear explanation why the vitreous is involved, I mean, it gets complicated. For example, if intravitreal canalog was injected, let's say the patient had cataract, diabetic macular edema, cataract, and had cataract and canalog, that becomes a bit difficult.
Okay.
But if you're not sure, or if you cannot explain it, and the vitreous is involved on the B scan, or you clinically the vitreous is involved, I would treat it as endophthalmitis.
Okay.
So let's move on with the case. So this is on the ninth post-cataract day with this appearance of the eye. It's a little bit inflamed with anterior chamber reaction or hypopyon that we started to work from the sideboard, as we can see. And I think it's in your opinion, is it a mandatory step to decrease the bacterial load inside the eye and to clear up the media so you can proceed with the vitrectomy? So you usually start with intervening with the anterior chamber?
So yes and no. So if the view is not too bad, I would leave the anterior chamber for now, and if I can see the infusion, I'd like to get a vitreous biopsy under air.
As a start,
But the criteria is that you have to see the infusion cannula tip, right? So, and I would prime, still would prime the machine with fluid, but then after that we'll shift everything to air outside, so make sure that the infusion cannula has air. Even we prime the cutter again with air, and then I would do a vitreous biopsy under air. Then I would stop and go and clean the front better to see better and deal with it. If there's no view, I would do the vitreous biopsy after clearing the front. And usually, not too much fluid will go to the back.
Okay.
And you take two biopsies, one from the AC and another one from the vitreous, or you count only if you can take a vitreous sample?
We're already in the eye, so we should be able to get an aqueous sample, a vitreous sample. But let's say that the view is very bad and I really cannot see the tip, then maybe I will take a sample and I will send it anyway from the antechamber. If I think it's going to be very difficult and may not be able.
In this case, if we can proceed and we can do it.
Yeah, I'll do a vitreous biopsy under air because you get a big sample. The yield is probably better.
So we moved on in this case, and we were lucky to clear up the vitritis, severe anterior vitritis, and to remove the membrane anterior to the IOL. And I think this is a little bit more better view that we can move on with
that's
the
fantastic view.
So basically, we will learn before that, don't try to remove or to induce a PVD in these cases. But in my hands recently, I tried to de-roof all these loculi of probably vitritis or like a pus collection in the retinitis area. And I'm very cautious not to pull anteroposterior to avoid any iatrogenic breaks. So do you find this practice or this modification, is it of a benefit or it's more hazardous to the retina in such inflammatory cases?
I think, to be honest, if you can clean everything, even the vitreous base is fantastic. But the reality is the retina is very friable. Your view is not good. The retina is very thin, friable, and inflamed. And you can get away with it without causing a break, but you also can have a break. And
it's not a reproducible step.
I don't do it I don't do this anymore.
But would you leave the
Yeah, I would leave everything. I would just I do, like vitrectomy is like PPV, right? So I add another P before the PPV, and I think I read this somewhere. I didn't come up with it. So it's proportional to vision parasplantar vitrectomy. As far as I can see, I can remove. Once I feel the view is not good, or I've cleaned to the disc, that's for me is the stop. I don't try to induce hyaloid separation, and I also do not shave the
And
periphery.
does this go away with time?
Yeah, I think they do better. I mean, ideally, in the ideal world, I think if you clean and shave, it's better. I mean, you could argue that, even like cleaning the periphery, you may decrease the risk of cyclitic membranes and hypotony. Although, to be honest, I've seen like cases that are completely loaded with pus in the periphery and they do well, but also I've seen cases where they don't do well. But I think it's all benefit risk ratio. So for me, it's just cleaning in the center, seeing the disc enough, and come out.
And in some practices, in the infusion of the retracting machine, they add an antibiotic, and they propose that running this antibiotic inside the eye for like half an hour would add more
benefits.
antibacterial effect. So how do you find this practice?
I don't agree. I think the contact time is very important. I think it's also a medicine which gets diluted. I'm not really sure where this is coming from, but I've heard this. I've seen people advocating this. I'm not really aware of what's the evidence. I think contact time is important, and I think giving the injection at the end is more than enough. And these are very high doses of injections that we use, or not high dose, high concentration, which are enough. They are what they're called super MIC, so like 100 to 200 times the minimal inhibitory concentration. So it's enough to go into biofilms. That's why we don't remove the IOL, because even if the organisms are making biofilms, that's enough. So I don't think there's any more need for anything, and I think this is more than enough.
And I would like also to know your opinion about the new trend for injecting povidone, iodine inside the eye.
I mean, I love iodine, but I don't have any experience in putting inside the eye. I've seen the papers coming out from mainly Japanese group, and I think in this Alexandria here, right, as well. But I really don't have any experience. But I think it's fantastic. I mean, I think iodine is fantastic, but I did not use it. I do not have any experience with it.
How about medical legal?
Yeah, I think that's the thing, really. But I think if there are
concern?
studies, if more surgeons are doing this, I think you probably can get away with it. And
I think even the fortified eye drops are not legalized, or it is not an FDA approved protocol for the endophthalmitis.
Yeah, no, absolutely. I mean, there's no FDA approval for steroids, even in uveitis. But I think I would do the best for the patient. I think if it's supported by evidence, and I think so. But I really do not have any experience. But maybe, yeah.
Yeah, another question. I know you're throwing at you a lot of the mysteries around endophthalmitis, but some people, some surgeons or some practitioners believe that adding silicone oil is a bacteriostatic and could stop the spread of the organism.
No, so I agree. Silicone oil is bacteriostatic, but if you think of like the minimal inhibitory concentration, if you're within 4 times the MIC, that's a bacteriostatic drug. And that's, for example, like using a bacteriostatic antibiotic, like Bactrim or something. But then if you're 10 times the MIC, that's a bactericidal medication,
So
antibiotic.
you mean with the injection you're doing better than a bacteriostatic?
Absolutely.
agent, right?
With the injection, you're now we're talking 4 times, 10 times, we're talking 100 to 200 times. So I'm not really sure why would use the oil. I mean, I think oil has a role in PVR detachment, for example, but I think otherwise I would not use oil in those patients, really.
And in cases like this, if you proceed to vitrectomy, in your experience, how long would those patients keep kept under fortified eye drops?
This is a great question. If you ask me, I never use fortified antibiotics unless there is it's coming from blebitis, or there's a corneal, like coming from, for example, a suture-related abscess. But I don't think really, I think the main treatment, and this is, in my view, is a very important point, the main treatment of endophthalmitis is not vitrectomy, is not fortified antibiotic, is not systemic antibiotic, not subconjunctival antibiotic, it's not antibiotic on the solution, it's intravitreal antibiotics. Otherwise, anything else you're doing is adjuvant. For example, we give these patients ofloxacin for 3-4 days and we stop it. But I think the second most important treatment is steroids, because you want to decrease the damage from inflammation. Yes. So we do not use fortified antibiotics.
When do you start systemic steroid?
Systemic steroid on the first day, or we sometimes use intravitreal dexamethasone.
Okay.
But my advice is not to use intravitreal Kenalog, because then if the patient gets a sterile inflammation, then it becomes very difficult. The B scan becomes very difficult. But but I don't think there's any importance for
So you give
45 days.
oral steroids,
We
right?
give them oral steroids. We give them oral antibiotics unless they are very old. The quinolones can mess up old patients. They get into even like mental issues with it. So I think all these are adjuvant. The main line of treatment is intravitreal antibiotic.
Okay.
So we are giving oral steroids while there is an active infection.
Yes, but you already gave them the treatment,
Yes,
right?
exactly. I'm just getting the point that
Yeah.
steroids will not weaken the immunity of the
Yeah.
patient or cause it won't get us back on one step or
No,
another.
even in fungal endophthalmitis,
help.
which I don't do to be honest, but in fungal endophthalmitis, there are several studies from India where they use systemic steroid and even intravitreal steroids fungal endophthalmitis. I don't do it, but and even like a line of treatment for toxoplasma retinitis is intravitreal Clinda and intravitreal Kinalog. So I think as long as you're treating the infection, you can use steroids. The problem is if you're not treating the infection.
Okay.
So one last question about this scenario. So by the end of this surgery, we have one of two fates, whether it goes the good scenario and the patient start to improve and we did everything in our hands. The other one that we can see that there is a reaccumulation of hypopyon, the pain started to appear again, which is a very rare scenario in such a condition, but it happens in some cases. So would you re-inject after the vitrectomy?
Yeah. I would re-inject again, and I think I would keep re-injecting as long as there's some potential of keeping the eye. Again, this scenario is not common, but yes, there are patients who go into phthisis and who do bad, but that scenario is small.
Okay. So we'll move now to
another case.
Case with a similar condition, but this is a trap case that was complicated in the fellow eye with an absolute glaucoma, and that one was losing his vision because of the refractory glaucoma, and this patient went for a shunt surgery 18 years ago. Then he presented, so he is a single-eyed patient, and he presented with a received diminution of vision that was injected by his glaucoma surgeon. 2 days before he presented to us with this PL vision after he was a hand motion vision. So is it now an indication for a vitrectomy, or do you still re-inject that patient?
I think this is a great question, and no one knows the answer because the endophthalmitis vitrectomy study looked at the cataract and secondary IOL, post-IOL, and for this, actually, you're thinking this is a different ball game with more virulent organism. So I think early vitrectomy for them is a good idea, but the eye is very hot. So what I would do in these patients is I try to inject them very quickly, and then in 24 hours I would go for vitrectomy for those patients and have another injection as well.
Okay.
25 minutes there is doubling of the organism load.
Yeah.
So I would do an injection, then we can talk.
Okay.
This case, and again, there's a hazy vitritis media, but much better than the one before for the cataract. And again, the same protocol I used, that I started to move or try to remove the as vitreous or pus loculi over the retina and remove these vitritis, and without harming the area of retinitis as this one. So we discussed this before, that you don't advocate this, but as long as there is no harm and we can remove as much as we can proceed, right?
Yeah, I'll be very cautious. I may puff a few things with a back flush, but even you have to be careful because I had this in diabetics. I did not have this in endophthalmitis. You can even in diabetics, I've opened a hole with the back flush. When the retina is thin, you can just puffing. You can open out.
What
be very careful.
I'm trying to remove, as you can see, the only fluffy material. But when I try to induce this BBD, when I find that it's it wouldn't progress or it wouldn't propagate without harming the retina, so I stopped and then I shifted.
I think that's the best thing.
So okay,
that's what I would do.
And you inject that at the end of the surgery?
Yes, I like what you're doing, and that's what I do. I inject from one of the trocars at the end. Usually I would leave air, but still I would inject the same dose.
whenever it was injected before the surgery, no matter you will inject by the end
Yeah,
of the
I
surgery.
would inject.
Okay.
There's even like argument to use a lower dose of vancomycin and re-inject it routinely, because the vancomycin works better by, like, it's more time dependent than dose dependent killing. This argument is coming from a Dutch group, but we usually don't do this. We usually do inject like 1 milligram or 2 milligram and repeat only if it's not getting better. But I think the antibiotic risk is low, so I think you can repeat it. I repeat it if I'm going for re-injection, because they are usually not getting better.
Okay, great. So the third one is about the chronic endophthalmitis, and there are some debates whether to remove the lens, whether to keep the lens, to remove the capsule or not. And this was an unclear case that was presented to the anterior segment surgeon 6 months after the uneventful surgery, and he was referred to another anterior segment and uveitis consultant for a missed particle or a cortical remnant in the AC. Then he was suspecting that this is not just an area of left material or left anterior cortical matter, and he was suspecting that there is some uveitic element going there in the posterior segment. And he also thought that this could be a drop lens matter. So would definitely the ultrasound will give you a perspective about what is going on behind this opaque material. But how would you judge, is it a uveitic case due to a lens matter, or is it an endophthalmitis, a chronic one?
Yeah, I think it becomes difficult when it's referred to you from outside. But I think timing is important. For example, if you have a lens matter, then this would be there from the beginning after the surgery.
Not after 6 months.
Yes, and the patient also would be like, usually there's inferior corneal edema because of the lens matter. So usually there'll be corneal edema. And that's why, like a corneal edema, that's actually one of the questions sometimes we give the residents. If you have post-cataract surgery and corneal edema, which is more inferior, what do you suspect? Retained lens matter. More severe could be related to the wound or descemet membrane detachment. So I think something like this. The other thing is too much. It's not only there's too much whitening in the vitreous, right? So it tells you that there's significant inflammation.
Mhm.
So I think that should trigger the thought of infection. But yeah.
And again, would you start by injecting or clearing the AC and injecting, or you proceed with vitrectomy?
So it depends. I mean, this eye looks very angry. But let's say we're dealing with more like a chronic endophthalmitis type, where you have like a low-grade rumbling inflammation, like very low grade, right? In these eyes, and usually they will be like a plaque on the posterior capsule, right? And so in these eyes, I usually do one trial of a conservative treatment, which is antibiotic injection. So I would do a tap and inject.
But you don't believe that it will work most of the time, right?
I think most of the time it does not work.
Yeah, not like acute.
Yeah, most of the time does not. And I think,
thing.
then the second surgery is usually a radical surgery. Like in gynecology, they say like hysterectomy in toto.
Okay.
I like this word, in toto. So I would do like a capsulectomy in toto. Everything has to come out.
But not the IOL.
No, the IOL. Everything comes out.
So the IOL too.
So usually I would give them a trial with the steroids, drops, and intravitreal injection. If that does not work, everything comes out.
Okay, so I was more aggressive. So we went for just trying to clear up this cortical matter, which was found not to be lens matter at all. So this was a fibrinous exudate from an inflammatory condition. And at that time, we suspected that it could be a chronic endophthalmitis with this retrolental plaque, which is very related to the chronic endophthalmitis, and started to remove all these dense vitritis retrolental. And as much as we can, we try to clear up the media and to remove the membrane over the lens in the AC. And you said that you are going to remove everything. Huh?
Yeah, so I usually do, again, all the endophthalmitis, I do try to do vitrectomy under air.
To take the sample.
To take a sample. Very rarely I would do a dry vitrectomy. The problem with dry vitrectomy is the eye collapses, but I've done that as well. And then I would here again the vitreous it depends on, you don't want to really get into problems, but usually this is not classic for a chronic, because usually the chronic is not too much inflamed.
Okay, it's low grade inflammation.
Yeah, it's low grade inflammation, so you may not induce hyaloid separation if it's difficult, but you're able to remove most of the vitreous. But I'll take the IOL out with the capsule, with the zonios, everything comes out.
You didn't try to leave the IOL?
No, usually if we go for vitrectomy, I go for remove everything.
Because I have a different experience. It's not much of an experience, but a few cases that I left the IOL and they did fine.
Yeah, no, I think that's fine, and that could be really an argument that you do even like one more attempt of a conservative approach. Yeah. I mean, these cases, I don't think there is like hard evidence to advise, and also the other thing, you have time to do several things.
Yeah.
So so you could try to conserve.
Not like acute cases, because
exactly.
Acute cases time matters.
Yeah, so you could try injection, then if it doesn't work, you do a conservative type vitrectomy. If it doesn't work, then you come back and remove everything. But just for me, that's what I've been doing, and that's how I
have a case that I left the IOL. He went very fine, and then he had another bout of of inflammation with low dose oral steroids. It went well.
Exactly. That's why I removed the IOL, because what happens, they colonize.
Okay.
And they make like really biofilms on the IOL, which it seems like when it's chronic, these are like very strong. Even the antibiotic cannot penetrate in. Okay. But exactly, and that's my experience when we're not aggressive enough with these cases to remove everything. They just keep coming back, and usually we end up removing everything. So
you're radical from the start.
So usually I give them one try with antibiotics if it doesn't work. But having said that, I think these cases, you have time, you can try several things. And if you end up sparing them like a radical vitrectomy, I think is very good.
Okay. So we are now between two opinion between a stepwise approach, that's to go vitrectomy and to leave up the IOL and the capsule and see if it goes well or it's going to need a steroids, or we can remove it from the first
I think it's still stepwise, because the first step is like steroids and intravitreal antibiotics. Then my step 2 is just to remove everything. Maybe like that could be a step 3, and a step 2 you try a more conservative vitrectomy. But it's just what I've seen before is that usually you end up keeps like inflammation coming back. So I think it's just remove everything, because it's just.
Do you have a problem with hypotony post-operative in these cases?
In vitrectomy for endophthalmitis in general, I think usually if they go into hypotony, that's probably, unfortunately, they will go into like phthisis, because it's a serious body issue.
I have a case that went into hypotony for a few weeks post-operative, but I just saw him today, and his IOP is 12.
Oh, that's fantastic.
But he has an iris bone vein.
Right.
So I won't try to break this bone vein now.
Yeah. So that might be.
This might be what's saving the eye.
Yeah, and that's usually. I mean, I've seen this as well. Usually, it's temporary, and then I think the problem is in uveitis, chronic hypotony is very bad, and there's nothing really you can do. It's just the serious body is like, damaged, and there's nothing you can do really.
Okay. So we'll move to next entity, which is the endogenous endophthalmitis in a catheterized patients. This one was a prostate cancer patient that was operated 2 months ago, and then he had a catheter, and he presented with this diminution of vision and reaction just 2 months after the surgery. And we suspected a candida endophthalmitis, as well as the ultrasound was suspecting this as well. So he started a systemic voriconazole, oral voriconazole, but the vision wouldn't improve. So would you inject an antifungal intravitreal before doing vitrectomy, or would you proceed stage 4 to vitrectomy?
That's a great question. So I'll tell you what I do in these patients. So I think the difficulty in this, and if I'm like aggressing too much, just tell me and we go back to the to the question. So usually the difficulty is like going which way? Is this an endogenous bacteria or endogenous fungal endophthalmitis? So usually what we do in these patients, and we tend not to admit patients, like we don't like admitting patients, but those patients we tend to admit them, get blood cultures, get echo, and get the infection disease to have a look on them to try to find the source of infection. Then we try to rethink, is it bacteria or fungal? Let's say in this case you're thinking fungal. So if the lesion is in the choroid still and is not raised, then it did not penetrate into the outer blood retinal barrier. And in these cases, systemic treatment is fantastic, and you don't need to give anything intravitreal. But if the lesion is raised or there is vitreous involved, then it has penetrated into the outer blood retinal barrier, and in this case, they need intravitreal treatment, plus or minus vitrectomy, which may be needed.
So in these cases, you inject first and then
so remember when we talked about the post-procedure endophthalmitis, and we said the main line of treatment is intravitreal.
Yeah.
Here, the main line of treatment is systemic antibiotics or systemic antimicrobial. Plus, if the lesion is raised or the vitreous is involved, adjuvant intravitreal antimicrobials.
So vitrectomy, just you do vitrectomy when it's not going.
So we did a study on this, and we found that vitrectomy does not improve the vision, but it decreased the risk of retinal detachment later on.
Okay.
So I usually, again, it's a hot eye. I try to calm the eye first and then do vitrectomy later on if I need to. If things are not getting better, again, in my experience, they usually do better without vitrectomy. But if things are getting worse, then I will do vitrectomy. But I think we need to differentiate between vitrectomy to treat the infection and vitrectomy to deal with problems from infection later on, including membranes, detachment, or persistent vitreous opacities.
So this case later on complicated. It was under the systemic antifungal, and it was injected by an anterior segment surgeon with an intravitreal antifungal drug. But when he presented to me, he presented with a traction retinal detachment.
Yes.
So this was the complication. After removal of the cataract, do you intend to remove the capsule as well, or do you preserve it in such inflamed cases?
No. So I agree. I usually open it and leave it. Later on, I can put an IOL on it. If it's too bad, then I may take everything out. Just pull it with the forceps and take everything out. But initially, I would probably, if it's not too bad, I would just open it. And usually I would not put an IOL.
Open the posterior capsule.
Open the posterior capsule.
And why is that?
I don't know. I think they get synechic and then it opacifies and you cannot see well. So I would open it, but still leave enough to put in the sulcus. Or even, sometimes we have a couple of patients who did very well, and we even were able to put an IOL in the bag with the posterior capsule opening because it was like small enough.
But I have the sense that probably I may need a silicone in this case. So I need to try to preserve the posterior capsule as much as I can. So I try to diaphragm.
I think that's a great point, really. So you're right.
So we moved on, and this is a different issue in an inflamed endogenous endophthalmitis, that we have now attraction. So I believe that we have to remove every piece causing this traction retinal detachment and try to remove all the vitreous and to even induce a PVD if we can. So I know that you don't agree that we have to be an aggressive, but in such a case with already detached retina, so how would you proceed?
So I think here, you need to decide whether this traction or combined traction rhegmatology. If it's traction, I would just clear the center, clear it, and just do minimal, even if I need to come back. But I'll try to avoid getting a break in these cases because I feel like a break is not going to do very well. But you have all the ingredients for PVR there. So,
but how can you judge? Because in some areas, as we can see, there are some severe retinitis with this whitish material. So probably there could be a tear that we couldn't find at that time.
I think it's like diabetics. In diabetics, most of the time you can tell from the configuration, and once you see the retina, you can tell from the configuration that this combined traction rhegmatogenous or mainly traction, the configuration of the retina, the subretinal fluid. So
what was the vision pre-operative?
PM.
So did you see the fundus?
No. Just from the ultrasound, I found that there is a traction retinal detachment 360.
Because if I saw this fundus, I would decide that this is an inoperable case.
Yeah.
It's really
No, it's a very
difficult.
tough case.
Yeah.
But yeah, I think if it's combined, then you'll have really to remove more and try to deal at least. I mean, if you see the breaks, I think they're important as well. Even in combined, you can leave traction if it's away from the break, and that's what I do even in diabetics. If like you have bad traction, but it's away from the break, you can leave it, and still I use gas.
But in such a crumbled retina, I even can't find the macula of the optic disc, so I don't know.
Yeah, but the argument is, no, I think if you're rheumatologist and you cannot find the break, then you want to try to clear and just deal with whatever is there. But if you can see the break, or if you think this is just traction, I would rather just deal with it.
It's a diseased posterior hyaloid. That's my belief.
I think so. It's
It's a diseased eye at all levels. It's posterior hyaloid, the vitreous, the retina, the choroid, everything. So at this point, I was lucky to find this plane between the real vitreous and the retina, and I was eager to remove everything that causing this bulging of the retina and tracting this, even the macula. So I proceeded with trying to clear up this area and try to avoid any more iatrogenic break rather than the one in the superior temporal. But regarding this whitish area of retinitis, would you try to tackle it, or you will leave it with just for the systemic antifungal or whatever systemic treatment, or the intravitreal injection at the end of the surgery?
Yeah, no, I mean, I've learned the hard way, and my experience really, less is more. I mean, I just leave it and just deal with what I can.
Would you?
I mean, it depends. I mean, if you have a one break and you've relaxed the traction around it, I would still use gas. If you have like multiple breaks and there's lots of traction around it and it's all like messy there, then I think that's a great case for oil. So that's all I do. But in general, I try to do less and avoid oil as much as I
really
can.
intrigued to know the recurrence rate with in your hands.
I mean, to be honest, I don't think it's high because usually we don't operate on these patients because they do very well with injections. So
even with traction?
no, restriction detachment is different. Now we're talking about endophthalmitis.
Just the endophthalmitis.
Yeah.
No, I mean with PVR usually I use more oil than gas, unless really it's a PVR case, for example, where you have the break away from the traction, and I mean then I think that's a good case for gas.
Mohammed raised a very good question. If we can see, if we have a good view for this fundus, would you operate such a case?
I think it depends. If the patient, like let's say this is an 80-year-old patient, then I would not operate. But let's say a 50-year-old patient who's medically not too bad and the patient is motivated, I explain things to the patient. But like 80 years patient, other eye is good. I probably would not operate unless the patient really insists. But I would tell him anyway.
I think the most important question is the condition of the other eye.
Yeah, absolutely.
If the other eye is okay,
the other eye is okay, but there is a possibility that patient would develop another endophthalmitis in the other eye. So this is a concern that is different between if it is a post-acute cataract surgery or it is an endogenous one. So this patient was really an 80s patient with otherwise a general very good condition.
Yeah.
And after counseling the patient a lot about the long-term outcome of this surgery, he was asking to proceed with the surgery.
Yeah.
Whatever
No, I think that's very sensible.
Yeah, but my question is, what if we left this eye and it's going to proceed with the long-term sequelae of a traction retinal detachment in the eye with a glaucoma, increased in the intraocular pressure, then neovascular glaucoma, and then atrophy of the eye. So would doing a surgery to avoid just long-term sequelae for traction retinal detachment?
The problem is doing the surgery and going into the same complications. That's my
concern. I agree.
That if you did the surgery and you did everything right, and then the patient had the same complications and ended with atrophy of the eye. So that's what I'm thinking about.
Sure, but you have done what you can offer. Yeah. So,
my view is, I'll tell you what, something I know which is very interesting. A group from Oxford, they looked at patients who had PVR detachment with multiple surgery and ended up with poor vision and oil in eye, and they defined poor vision, I think was something around counting finger, and the other eye is good, right? And they did like a quality survey vision, visual, what do you call it, the VF questionnaire,
VFQ
questionnaire, And actually, the results was that there was not much really benefit from like a poor seeing eye with oil. So you would expect that they may benefit a bit from it, but they actually were not benefiting that much. Which I'm not trying to say not to operate, but I think just know in your mind that, okay, well, this eye is not seeing, but is painless. We may operate and create it to a non-seeing, painful eye because of surgery and oil problems. So I think, yeah, I would run it by the patient, especially if they are old and the other eye is good. And usually if it's a fungal endophthalmitis treated, then the other eye now is unlikely to be affected. But I think it's all about the patients and you like educating the patient to make a sensible or to help you reach to a sensible decision that you both agree with.
I think the conversation went into more of a
Yeah, more of a philosophical.
yeah.
I think you know, explaining to the patient the outcome, and sometimes I use a term, an eye in the bag, that we're not going to bring vision in this eye, but maybe this eye will be seeing like hand motion in case, God forbid, something happens to the other eye. That usually more benefit if it's a young patient.
So it's in the context of every case. So
Yeah.
So it's not a single rule that will apply for everyone.
I think age of the patient, the state of the other eye, what patient wants, also to explain to the patient this eye in the bag concept.
So after this step, I found that I can even peel a membrane over the retina, and the macula started to appear. And I'm trying to.
And this white patch.
I'm going to open
disc,
it. I'm not going to leave it anymore.
Yeah. Okay.
No, the desk was not under this area. This is a temporal retina. So like when the retina started to lay down and unfold, so that was the temporal part of the retina because this is the left eye, and the other part was the nasal and the optic disc that is under this folded retina, and it's going to unfold now, and going to have a much better appearance than what we see now. So
I see it's a 2-hour surgery.
A difficult case, really. Yeah. You did very well. It's a very difficult case on thin retina and fiber retina.
So if it's a lengthy one, would you terminate in the middle?
I want to say no, but in my heart I believe yes. If it's a lengthy surgery, yeah.
But seems you're winning. You know, it seems so far you're winning.
Yeah, and even after fluid exchange, the look will be much more appealing for me that I have done a very good work after 2 hours, and even after the first post-operative visit, and the patient started to shift from PL to slightly hand motion vision. That for me was
PL plus.
Yeah. So I know that this is an inflamed eye, and there was some iatrogenic breaks and this loculi of arthritis. So would you have another option, or how do you feel about adding laser in such an inflamed eye?
Yeah, that's a good point. So one of my previous bosses, when I was a fellow many years back, his view was that if you're putting oil, then, you know, especially if you believe in oil, you don't need to laser, right? That's the tamponade, because now it's all very inflamed. Don't do much laser, just put the oil and then you can laser later on.
Okay.
But you know, I would still try to laser if I find everything friable. I would not even laser around the breaks.
If you've been in surgery for 2 hours, you would laser.
I think sometimes it's just friable, and even like when you do the laser, it pops, right? Because it's all very friable. But I wouldn't do like more extensive laser because I don't think it adds any benefit. I think I would just laser the breaks.
What was the final visual acuity?
Counting fingers, 2 to 3
I mean, it looks great under oil.
This is 10 days.
Yeah, don't take any more pictures. Optus machine is down.
That's 2 months.
2 months.
Oh, here you go. You're brave.
Yeah, okay.
So it went well in my hand.
No, that's fantastic.
I was lucky.
That's fantastic.
So the last one is a more aggressive, in my opinion, because
more aggressive than this one.
Yes, because it's a single-eyed patient whose the other eye was lost due to an absolute glaucoma, and he had a trap 38 years ago. And they presented all of a sudden that he felt that there is some pain in his eye, that he went to sleep. He came up in the morning with this ugly eye and painful eye with a PL vision. So he presented to us, An ultrasound showed a severe inflammation. We injected that patient, didn't improve, and the patient is still in pain. And he is a one-eyed patient due to lost fellow eye due to an absolute glaucoma. So, how would you proceed in such a case?
So he was injected, right?
Yes.
Okay. Yeah. No, I would proceed. I mean, back to the discussion about glaucoma post-trap surgery. I would proceed. I'll be like early on with vitrectomy in these cases. So I'd inject them, and in 24 hours I'd arrange for vitrectomy. Maybe a good point as well, just to mention, the problem with trabeculectomy is like a bomb in the eye for life. So I think it's important for these patients to understand that if they have conjunctivitis, that needs to be seriously treated. And to tell them like, okay, pain or red eye, we have to have a look on you. And that's maybe one of the advantages of tube versus trap, is that you have less risk, you have more exposure of the tube, but you have less risk of endophthalmitis.
And as a bleb associated endophthalmitis, so as we know from literature that strep and staph epidermidis are the most common.
Yeah,
So-
strep, pneumococci, and actually, what's the other one? Klebsiella or...
Staph epidermidis is the second one.
Yeah.
So would that add to your aggressiveness to treat with, or?
Yeah, no, I think it's an aggressive organism. It's a late presentation, and also, I mean, you're extrapolating from the EVS and other studies, but there are no really like big study that looked into this. So I would do earlier vitrectomy, but still I would inject them first.
So as we discussed before, that we would try to clear up the media and to try to clean the anterior chamber. So I was thinking that this white rim in the periphery is a keratitis. So while I'm trying to remove the membrane, the pupillary membrane, I found that this an exudate, a sheet of exudate that is lying under the cornea. And I was eager to remove this membrane, and it was very relieving to me at the first part to find this coming out in total.
That's beautiful.
So in such a case, you would manage to clean up the anterior chamber first.
Yeah, I would. And this is like we just, I think that also opens the discussion whether you would take if there's too much fluid gonna go inside the eye, I may take an AC tap, because maybe then the vitreous tap, I may not be able to do a vitreous tap because I'm not going to see the infusion cannula, or it will be like too much fluid went to the back, so diluting the vitreous. So I will take an AC tap as well from these patients, although the yield from the AC is low, as we know.
Yeah, we send an AC tap, and we send this exudative matter to the lab as well. But my question, in such a case with an older trap, you wouldn't be afraid that maneuvering the anterior chamber, gushing more fluid, would open up the old bleb?
Yeah, it may be, but I think usually the problem in these patients is a mitomycin bleb usually. So it's a chronic leaky bleb. So there's micro leakage in these blebs. So I would be afraid, but I think there's nothing, you have to do it. You have to clean things.
So this is after cleaning up, and we started to do a blind vitrectomy, and I was very cautious to go for a retrolental with a retroillumination. But all of a sudden, we find that the bleb is leaking now, and anterior chamber fluid is coming out from this. And I think this is the source for this very late endophthalmitis in such a trap case. So in literature or in experience, how common do you find this bleb leakage after a very long time? Common, right?
In the bleb rate endophthalmitis, common. And I think, that's usually a mitomycin bleb.
So with this open-eyed, so how would you move? And as we can see now, after injecting a viscoelastic in the AC, there are some more egress of this anterior chamber content. So when you find that there is bleb rupture as this one, so how would you cover it? How would you try to calm down this eye? And probably we are not going to able to complete this vitrectomy.
Yeah, I would do exactly like what you've done. Put viscoelastic and then try to do, as I say, like proportional to vision vitrectomy, and don't be aggressive. Just remove the core to open space. And then I would try to address, unless everything is very friable and there's not much I can do, I'll try to address the bleb. So usually I would excise it and then put a tutuplast or a scleral patch graft, and also amniotic or a conjunctiva over it. Amniotic is the easiest. to put on
What
it.
about tissue glue?
Yeah, I think if there are small holes, you can tissue glue as well. But I think I've not done this because the ones like when it's very minimal, I just left it, and the one where it was bigger, then I grafted. And the third category is where like everything is it's a big mess, then I would just leave it. But I think, yeah.
And when you come to suturing whatever prosthesis that we are going to add, do you suture it to the sclera or to the edges of the old bleb or in the conjunctiva?
To the tutoplast or the sclera, I would suture it to the sclera, and then on top of it, I try to put an amniotic membrane. But sometimes it's even difficult, and you just end up with a sclera or tutoplast only.
So this one, I tried to cover it with this scleral patch, and I was hoping to salvage this eye as much as I can. So I started to suture it to the sclera and to the conjunctiva as a one suture, because I wouldn't try to open this inflamed conjunctiva, and I didn't resect the old bleb.
Yeah.
So I managed to fix this one, and I re-injected the fortified antibiotics again at the end of the surgery. In some cases, as this one, I tried to put povidone iodine at the end of the surgery. So do you find this, because I've seen in UK some of the surgeons try to finalize all of the surgery by
That's
this
what I
point.
do. I put iodine in all the surgery, even cataract surgery at the end. So even like with cataract surgery, I would put a drop of iodine. Then by the time I'm taking off the drapes, then I would wash it with some anesthetic drops. Then I put a viscoelastic on the cornea. That's what I do with all surgery.
Cataract, vitrectomy,
Yes,
everyone.
and the viscoelastic just to lubricate, and you don't have the tests. And I just wash the iodine so it doesn't sting the patient.
Okay.
Yeah.
So this is the appearance of the eye. It's 1 week post-operative, and the scleral graft is in place. And this is, again, it's much less inflamed than before, but at 2 weeks it has this large stained corneal ulcer, and the patient is now scheduled for keratoplasty and vitrectomy because he got a traction retinal detachment. So would you add or modify any of the procedure or any of the steps that this patient went through?
Honestly, I think you did fantastic. This is a great case, and I think it's a great outcome. It's bad that the patient has traction retinal detachment, but I think in this case, there's not much you could have done. And now at least you're dealing with an eye that is slightly less
Quieter.
angry and quieter. I think that's what I would do. So go for surgery with temporary keratoc prosthesis. Yeah, I mean, if you're gonna put oil, maybe put the cornea back. If you end up with gas, you can put a new cornea. It depends on what's happening there.
So a really depressing episode, I think.
Yeah.
We're always putting you in this in this role of depressing cases.
So to sum up what we have said, that in your opinion and even in literature and study, so for acute endophthalmitis, the first step is to inject patients and to wait and don't be aggressive with vitrectomy, right?
Yes.
And
the role of systemic steroids is one.
Yeah, I think steroid is really the most important adjuvant in my view.
Okay, and no need for long-term fortified eye drops after the...
No, not at all. I think the main treatment is intravitreal antibiotics.
Okay. And in glaucoma patients, it's a little bit more aggressive, so we have to tackle it aggressively than the acute endophthalmitis.
Yeah, so I think maybe be ready unless you have a good surprise that this 24 hours is better. I would go for surgery, and again, cautious surgery and re-injection.
So by the end of this session, we'd like to thank you, Dr. Ahmed
No, thank you so much.
And it really was our pleasure to be with us in Retina Chats. And
thank you very much.
Thanks for having me.
We hope to have you for better outcomes and better cases.
Yeah.
Okay, thank you very much. Stay tuned for the next episode.